The whirlpool sign is shown here in this child. This is a typical upper GI finding of midgut volvulus, where you'll have the SMA down the center of this corkscrew with the vessels wrapping around it. And here on the transverse ultrasound image, here is the SMA in the center with the SMV and jejunal veins surrounding it in this sort of corkscrew or whirlpool appearance. Here's another case more recently from our department. Here's the color Doppler with these distended, dilated veins around this SMA. And as you work your way up and down while you're ultrasounding, I think you can get the idea that there looks like there's a whorl or a target or a bullseye here. And again, we are looking at the wrapping of the mesentery around that central core containing the SMA. Unfortunately, if you have normal anatomy by ultrasound, you may still have malrotation up to 3%. So ultrasound cannot exclude malrotation. There are some newer works suggesting that if we can see the duodenum passing behind the superior mesenteric artery, that may conclusively exclude malrotation, or at least indicate normal fixation. Those studies still need to have some validation. They are not conclusive yet, and you still need an upper GI as the bottom line. However, when you're doing your due diligence and trying to find the cause of vomiting in a child, do look at the position of the SMA and SMV. It may give you indications that you need to go further. Abdominal pain in children has many, many causes. In many cases, never arrive at a specific diagnosis. We are generally asked to get involved to try to discern between medical or surgical disease. Imaging plays an increasing role, so much that at least in some developed countries, you can often wonder, did anyone examine the patient? Because as soon as the patient arrives at the physician's office or emergency room, imaging is thought of as a first step toward diagnosis. Appendicitis is still the most common cause for emergent surgery in children. There's an incidence of roughly 4 in 1,000 with an 8 to 9% lifetime risk. The classic symptoms are periumbilical pain moving down to the right lower quadrant, associated with fever, nausea, and vomiting. That said, there are often atypical presentations, and the younger you are, the more difficult the examination becomes, the less certain the symptoms are. So it can still be a vexing problem for the clinicians to decide which child has it and which child doesn't. Lots of ways to image appendicitis. Ultrasound versus CT are the primary ones. There's a lot of controversy about which is best. Issues of radiation and expertise, preparation time, and how many alternate diagnoses you may arrive at, that's for another day. But suffice to say, ultrasound should be the first line of imaging for children with appendicitis, because while we can have some very large children, which can make it difficult, it's still very useful. You need to use high-frequency linear transducers and use the graded compression technique to push air-filled bowel out of the way to let you see into the depth of the pelvis, find the cecum. Pain may limit the examination in some children. You do have to push hard, though if you go gently, you can usually overcome their resistance. And many appendices are retrocecal, so that can make them more difficult to see. And again, if you do not use graded compression, you really will have no chance of finding them. People have different methodologies. I start off with asking the child, where does it hurt? And they get to show me with one finger. Okay, they don't get to point to a whole area, they show me with one finger. And if they can do that, then that's where I start scanning. Alternatively, if they can't really define for me one particular point, or if I don't see anything when they do point to that, I tend to identify the ascending colon. I then move inferiorly down to toward the cecal pole. I find the terminal ileum and the ileocecal valve, and I know that the appendix lives just inferior. So if I keep scanning more inferiorly, eventually I'll find the base of the appendix, and then I can go from there. So again, gentle graded compression. First scan around with light pressure, get a lay of the land, get the child to trust you a little bit, and then slowly increase pressure. And it's important not only to watch the screen, but also something you can learn from surgeons is watch the patient. Watch the patient's reaction while you're scanning. There are some maneuvers that can improve detection, and the referenced article there was a nice study. You can do posterior compression. You can press in and press up. We typically scan these children with an empty bladder, but occasionally, especially large kids, you can actually use the bladder as an acoustic window. Sometimes you can roll a child up. You can use a curved array transducer on larger kids. But of all the maneuvers, I found this one where you push up posteriorly as well as down can really push air out of the way of the ascending colon and gives you a great view of the retrocecal colic gutter to look for appendices back there. So what's a normal appendix? 6 millimeters is still the norm. How often you see it really depends on the size of your patients, your experience, how long you're willing to take. I think we see it now in upwards of 75% of children. When first starting out, I probably only saw it about 10% of the time. Even if you don't see it, document your landmarks, document the psoas, document the iliac vessels, show that you were in the right area. The value of a negative appendix ultrasound in kids is a matter of debate. My opinion is that if I've got no abnormalities, I have no hyperemia, everything looks normal, that's a pretty reliable sign. And there is literature out there that suggests that the negative predictive value of a normal ultrasound, even without seeing the appendix, may be well above 90%. The normal appendix should be compressible, can contain gas or fluid, but you should be able to press it, as in this case, where we have a nice normal appendix. It's small, it has a normal gut signature with the different layers of the wall, and as you compress, you can completely collapse it in this case. Here's the same patient on a longitudinal scan, nice normal appendix. You see the tip well, there's no surrounding hyperemia, normal gut signature. In this case, again, here's a normal appendix. You see the blind ending tip, no hyperemia, no surrounding inflammatory change, normal size. Here's another case, nice normal appendix sitting on top of the iliac vessels here. Another normal appendix, slightly older case. Again, no surrounding inflammatory reaction. This one, while you may think it looks more concerning, remember they can fill with fluid. And in the old days doing barium enemas, remember that most normal appendices, 90%, fill with barium. So it's okay to have luminal contents. Again, normal GI wall, you see the layers well. There's no surrounding hyperemia or inflammatory change. This is just a normal appendix. Another one, the degree of hyperemia really depends upon your machines. And with technology changing, what's normal is a constantly moving target. So you have to be aware of, with your own equipment and your own particular transducers, what a normal amount of blood flow should be within the appendix. So an abnormal appendix typically is larger than 6 millimeters. It's not compressible. You may see an appendicolith. You have hyperemia with color Doppler. And I think a very useful sign is adjacent fluid or adjacent induration and inflammatory change in the fat. I found that one of the most reliable things to look for. So here is an inflamed appendix. It is certainly larger than 6 millimeters. We still have the normal GI wall. We haven't lost that. But look at this abnormal echogenic fat adjacent to it. So this inflammatory change adjacent to the appendix can be a really good tip-off if you had any doubt about this. This is an abnormal appendix. In the operative photo, you can see this very large inflamed appendix right here. Again, echogenic fat. Here's the appendix. There's a little bit of fluid around it, but in the transverse image you can see all this abnormal echogenic fat indicating inflammatory change in the periappendiceal soft tissues. Color Doppler in this case, or power Doppler here, shows tremendous hyperemia in the wall. You may not have uniform thickening, but again, we have 9 millimeters. This is non-compressible, hyperemic, little bit of reaction around it in this child with acute appendicitis. More cases, again, transverse image, not compressible. They will not like it when you do this compression. It certainly hurts, but it's a nice confirmatory finding that you do in fact have appendicitis. In this case, there is some hyperemia. The lumen or the appendix is swollen to almost 9 millimeters. No abscess, just a simple acute appendicitis.